Okay, moving right along to twins. So we know we have two basic types of twins. We have fraternal twins and identical twins. So with fraternal twins, that's when the mother or the pregnant parent ovulated twice. And they might ovulate twice because they're just genetically more inclined to do that, or they might have ovulated twice because they're on a medication that helps stimulate creating and then ovulating more than one ovum. So, for example, Clomid. Regardless of why two ovums came, genetically they're essentially siblings. So then that means that there's two ovums going through the fallopian tubes, two separate ovums attaching and embedding into the uterus for implantation, creating two separate placentas. So that's two chorions. So if you have two chorions, of course, you'll have two amnions as well, since the amnion is that inner bubble right next to the baby. And there would be two placentas. And on imaging, it could look like they're fused together, but it is two separate placentas, regardless of if it's challenging to visually tell if it's more than, if it's one placenta or a fused placenta. Okay, so that's our dizygotic twins. Now for monozygotic twins, it started out as a single ovum, and then depending at what point it's split into two separate babies, that's going to determine what we get for a placenta. So if the split happens pretty early on, then you essentially have the same situation as you would for fraternal twins, where you have two separate placentas, two chorions, two amnions, and it could look like a double placenta, where it's separate, or they could be fused together. It could be either way. In contrast, if it takes a little bit longer before the split occurs, then you could have one chorion and a single placenta, and then either one or two amnions, again, depending at what point the split happens. So it can be that both babies are inside one larger bubble of an amnion, which is inside the larger chorion, or you could have one big bubble, that's your chorion, with two little bubbles inside, your two amnions, with a baby in each one. And again, that just depends on the timing of when the split happens. Okay, so in this image here, you can see that there's three ultimate options you can end up with at the end. So A would be our fraternal twins or our identical twins that split early, where they have two separate placentas, two separate chorions, two separate amnions. In the second column, you can see that it took a little bit longer before the split happened. And so these monozygotic or identical twins have one chorion but two amnions, which you can see in that second to last row across. In this example, they have one shared placenta. And then in that right column, we see that we have one chorion and one amnion, which means that the babies are able to interact with each other directly without any amnion barrier between them. This is a lot less common and can also come with a lot more risk. This is also what you would see in the case of conjoined twins, which would be taking even longer to separate. So let's just run through each of those one more time. So dizygotic twinning are fraternal twins, and their placentation means that we have two placentas that may appear fused, two chorions and two amnions. And you can see that in this picture here. You can clearly see that they're in separate sacs. You can also tell that it's a pretty thick septum separating these two, so it's unlikely that it's two amnions that are just touching because that septum is so thick. It would be even more clear to me if I could see separate amnion bubbles within each of those two sacs, because then I would see that each of those larger sacs there would be like where you're seeing the amniotic fluid because it's dark. Each of those gestational sacs would appear as clearly separate if they had the amnions visible in them too, because each of those separate larger sacs would be my two chorions, and then I'd see the two amnions. But that thick septum is a good indicator here that they do have two separate placentas for dizygotic twins. Okay, and then this next slide are the monozygotic twinning options. The first option where you have two chorions and two amnions. And of note, this actually would look on ultrasound exactly the same as our dizygotic twins as far as the placentation goes. Well, all of it really. So you wouldn't know just being able to look on ultrasound. So we've got our two chorions, our two amnions, along with our two separate placentas that may appear fused. And again, this is just an early split. So you have one zygote that splits into two separate morulas, so two blastocysts that are implanting separately. And then our next monozygotic twinning option is one chorion with two amnions. And this is what the majority of twinning is going to be. On ultrasound, you can clearly see that gestational sac. What surrounds that gestational sac is going to be your chorion, and then you have those two little thin bubbles on the inside that contain each of those embryos, and those bubbles are your amnions. So one chorion, two amnions. So that means there's two embryoblasts contained in one blastomere, and they share the part that will become the chorion, and they implant together. And you can see the separation between them is clearly that really thin amnion. There's no sense of a thicker septum. I've had the opportunity to diagnose twins just twice, and both were completely unexpected, unplanned. They weren't taking any medications to make it more likely or anything like that. And it's really fun. So hopefully you all have the chance to do that down the line as well. Okay, final possibility is the monozygotic option for twins, where we have one chorion and one amnion, so they're sharing the same space, and again, that's rare. So this is due to pretty late separation. There's a high rate for entanglement, which is a concern, conjoined twins, or even what we call a parasite issue, where because they are sharing a placenta, it's possible for one of the twins to get a lot more of the nutrients than the other, so you might have one baby that's growing at a really good rate, while the other baby is suffering from intrauterine growth restriction. All that said, ideally babies are separate. And then here's an example of a placenta after birth. If you were to deliver this, it wouldn't immediately be obvious if you had two separate placentas that were fused versus if it was one placenta where there was one chorion and two amnions. And this picture is actually from Kenya. And one thing they do to tell if it's one placenta or two is they count the lobes, or cotyledons, and they counted a total of 20, which led them to believe that it was one placenta and not two. So I found that kind of interesting. And then here's one final twin image for you if that helps you with just thinking about the timing of when the cleavage or separation takes place and how that impacts what kind of placentation develops with twins. When we consider placental growth, it's interesting that generally placentas will cap their growth at around 32 weeks, and the growth starts a lot more rapidly than it does for the fetus. So the placenta grows pretty quickly, and then the fetal weight kind of kicks up, and the growth for the fetus increases after the placenta. So placental function, I'm not going to go into a lot of detail here, but just to give you a brief overview, metabolism, it contributes to fetal nutrient supply, rate of oxygen and glucose consumption, and really that rate is similar to the brain. And then naturally transport is one of its primary functions in that it's giving nutrients to the baby, oxygen to the baby, and then also getting the CO2 and any waste products back from the baby back to mom. So endocrine, we could really talk about placental hormones really in depth here, but just to touch base on the primary ones, HCG, or human chorionic gonadotropin hormone, is released by the syncytial trophoblast, and then we have HPL, or human placental lactogen, and then progesterone and estrogen. And then it does have an immunologic role as well. So it helps with protection so that the mom isn't rejecting the baby. There's a barrier there. The placenta serves as a barrier. And then IgG antibodies are able to cross through the placenta to give baby some immunologic protection as well. So in pregnancy, it's IgG that baby's able to get from their parent. And then after birth, it would be IgA through breast milk. And then let's just touch on our hormones a little bit more. So HCG, that's maintaining our corpus luteum for us while our placenta's not ready to be able to do all the hormones on its own. So that's the role of HCG, is to maintain that corpus luteum so it can continue to give off progesterone and support the pregnancy until our placenta's fully up and running. HPL is a huge player in promoting fetal growth. And then we have progesterone. Progesterone decreases myometrial activity, so it relaxes smooth muscles. So that's especially important for the myometrium because we're not wanting to have a baby prematurely, right? So progesterone helps keep the uterus quiet, so we're not cramping and having a baby. We refer to that as quiescence. It's also relaxing other smooth muscles like bowels. So it's common for pregnant women to be constipated, and that's because of this progesterone effect. It also constricts myometrial vessels, and it increases basal body temp along with a lot of other activities. And then estrogen is enhancing myometrial activity, promoting myometrial vasodilation, softening fibers in the cervical collagen tissue, increasing prolactin secretion, as well as a lot of other functions that we'll get into more when we're talking about pregnancy physiology. And certainly a lot of these functions are working towards preparing for birth. You'll remember estrogen makes things bigger too, so it's helping increase breast tissue, helping with endometrial growth. So certainly we'll get into all of this more for pregnancy physiology, but for this lecture, it's just important to be cognizant that it's the placenta that's making all these hormones in order to help drive pregnancy physiology forward. It's synthesizing these hormones and then releasing them into the maternal blood flow. Okay, so transfer of substances through the placenta. So this is all happening, or nearly all happening, through simple or passive diffusion. So this isn't active diffusion, this is happening easily and passively. So the biggest factor then is that it's going from high concentration to low concentration. That's what's most important in influencing transfer. So lipid solubility plays a big factor in that. Cholesterol is a main component in the membranes, and then moms often have higher levels of cholesterol when they're pregnant, which makes it easier for them to pass lipids from their body over to the fetal body. And then other characteristics that can influence the ease of something transferring would be molecular weight, degree of ionization, and then protein binding. And it's worth noting that sometimes there can be a little bit of capillary breakage where there might be just a little bit of mixing between fetal and maternal blood. So the way the placenta is set up is that's not supposed to happen, but if there is a little breakage and there is a little mixing, then that can also cause some things to transfer that weren't intended to be transferred. So for example, that's why we give prenatal RhoGAM, is just in the event that there was a little bit of mixing and mom's blood did come into contact with baby's blood, we wouldn't want her making antibodies that could attack this pregnancy or future pregnancies. And then this next slide here is just a reminder for how different types of transport can take place in the body. So the majority of what's happening here is simple diffusion, so that's that upper left quadrant, and then facilitated diffusion is the upper right. Bottom left is active transport requiring ATP, and then the bottom right is penocytosis. So the take home here is that all of these are used as aspects of placental transfer, and the majority is simple diffusion. So uteroplacental blood flow, that's typically going to be about 500 mils a minute once we've got a developed placenta. Factors that can affect that rate: changes in systemic circulation. So if mom, for whatever reason, has lost a lot of blood, then that's less blood that's being able to go to the placenta to nourish baby. Changes in the number and size of uteroplacental blood vessels or compression of those blood vessels. For example, if a woman is having tetanic contractions in labor where they're one on top of the other, that's going to keep those uteroplacental blood vessels compressed in a way that could compromise how much blood flow is able to go to the placenta and in turn the fetus. The uteroplacental blood vessels are running through the myometrium, so if the myometrium is contracted, then that's not providing adequate blood flow to the placenta for that brief amount of time. Having a break between contractions allows for plenty of time for the blood to reinfuse that region of the placenta in order to pass that on to baby. In thinking about other examples, if a pregnant person has hypertension, then that would be a factor that would consistently impact the amount of blood flow that's going to the placenta. Nicotine can also impact blood flow. And then with degenerative changes, we know that the placenta is growing in surface area up to about 32 weeks, but then after that point, it will decrease in surface area And so that's why it's important for us to keep an eye on how far somebody is past their estimated due date. Placentas aren't designed to be able to carry a toddler. They're really a time-limited organ. So then the main factor impacting how safe it is to go well beyond someone's due date is if their placenta is still functioning well to adequately give baby oxygen and nutrients. And there's two main ways that we can assess how the function of the placenta is doing. So because the placenta plays a role in how much amniotic fluid there is, we can look at how much fluid there is as an indicator for how well the placenta is still doing. So that can be in the form of looking for the largest pocket on ultrasound or for measuring an amniotic fluid index or AFI. It's worth keeping in mind that a maternal hydration status also plays a big role into how much fluid there is. So anytime we're going to check in on somebody's amniotic fluid, we want to make sure that she's really well hydrated so that if it is low, we can attribute it to potentially the placenta not doing as well, as opposed to wondering if it might be due to her hydration status. And then the other piece we can check is just how well is a baby doing by looking at their heart tones. So a baby that's really well oxygenated, getting plenty of fluids and nutrients through the placenta, but especially oxygen, we would expect their heart tones to look great. So doing like a non-stress test where we're watching their heart tones over 20 minutes is a good indicator that the placenta is still functioning well to give this baby what they need. So common practices for how that looks or plays out would be that after 40 weeks, we're fine. And then at 41 weeks, we go ahead and do a little bit of extra testing that includes looking at those fluids and includes doing a non-stress test. And then if that's reassuring, then we could go to 42 weeks. And then by 42 weeks, if we haven't seen a baby, then we're moving towards delivery. And if we do see that the fluid is low or that the heart tones aren't looking as great, then that's an indication that we don't have a placenta that's going to stay with us long enough for us to continue just staying pregnant ongoing. So it's worth moving more quickly towards a birth. For example, doing an induction. So that's a good segue over to sources of amniotic fluid. So amniotic membrane cells produce a little bit of fluid. So by that I mean the cells that are actually making up the amnion layer. They release a little fluid. Fetal urine releases fluid into the amniotic fluid area. Fetal respiratory tract, so thinking about just how when we're talking or sneezing or coughing, there's little bits of droplets that can come out. Same thing for baby. Certainly to a lesser extent when compared with fetal urine, but is still a mild contributing factor. The maternal blood to placenta and membranes contributes. Maternal interstitial fluid across the amniochorionic membrane also contributes. And then fetal skin cells would also be added to the amniotic fluid. And then I already mentioned fetal urine, but just to highlight this again, so fetal kidneys actually contribute 800 to 1200 mils a day, and lungs an additional 170 mils a day in the second half of pregnancy. So fetal kidneys are definitely playing a big role. And certainly babies will practice swallowing, so they'll swallow some of that amniotic fluid and that'll work its way through again, so that kind of gets recycled along the way too. Fetal urine starts at around 9 to 11 weeks. So the peak volume is typically around 32 weeks, so it builds and builds and builds till around then, and then it starts to wane from 32 weeks until birth. And the average amount is around 750 milliliters or so, with the majority falling anywhere from around 500 to 1200 milliliters. So there's definitely a variation there. So if it is especially low, we call that oligohydramnios. If it's an early pregnancy, usually that indicates something may be wrong with the amnion, like those amnion cells aren't able to contribute fluid. If it's towards the end of pregnancy, it's typically placental insufficiency. Certainly chromosomal abnormalities can cause it too. For example, if there were kidney problems, and the baby wasn't able to be urinating, that's a good bit of fluid that contributes to the amniotic fluid. So it could indicate a handful of different things. So that's oligohydramnios. And then polyhydramnios is when there's too much fluid. So that could be multiples, various chromosomal abnormalities. Half the time we don't know why it's too much. We'll explore that more in depth in your antepartum course. So for measuring amniotic fluid, there's basically two different ways to do it. So with a biophysical profile, or BPP, one of the factors that they're analyzing there is the amniotic fluid, and they do a deepest pocket for that. So for example, in the picture I have here, they would look for the largest area that they can that has amniotic fluid in it, and then they would measure a perfect vertical line from the top of that dark amniotic fluid area to the bottom, and whatever size that is, that would be the deepest pocket. And then the other way to do it would be to measure an AFI, or amniotic fluid index, and in that case you look in each of the 4 quadrants separately, searching around for the biggest pocket, and then you measure your biggest pocket in each of the 4 quadrants and add them all up together, and that's your AFI.